All right, we are picking back up with pulmonary edema pharmacology, and we are looking at the second drug that we can consider for the treatment of, and that is Vasotec. Vasotec is the trade name, enalapril, also known as enalapril. These are both generic names for the drug. I'm going to stop you for just a minute. If you have not gone to the RAS video, renin-angiotensin-aldosterone system, on your blackboard, you need to go ahead and view that first, because if you don't watch that before you watch this video, then this video is not going to make a whole lot of sense, because I'm not going to go through this again. The video that I found on YouTube does a really good job of explaining everything. So once you've watched that video, you know that an ACE inhibitor blocks the conversion of angiotensin 1 to angiotensin 2. And the ultimate goal is to inhibit the very last leg of this chain of events, and that is the release of aldosterone. And aldosterone in general causes water retention, and it causes arterial constriction. So it squeezes the vessels, arteries specifically, and it causes us to hold on to water. Another note to make that I didn't say in the first video: make darn sure that you know that fluid overload, water retention, is not a common cause of acute pulmonary edema. Okay? It is cardiogenic failure, which is a common cause of pulmonary edema. But can fluid have something to do with it? Sure. Right? So the thought here is that in addition to opening up the arteries and the veins, specifically the veins, so we're looking at preload reducers, with nitroglycerin and reducing the workload of the heart, in addition to limiting the blood that's coming back to the heart, if we make the body not retain as much fluid and give a medicine that in addition also helps to open up some of the arterioles, then we're going to help the problem as well. So again, we're treating the cardiogenic issue, not necessarily the respiratory issue, but make sure that you're ventilating the patient appropriately and providing supplemental oxygen or CPAP or whatever it is that you need to do to make sure they are breathing long enough for us to be able to treat this cardiogenic issue. So, back to the ACE inhibitor. Sorry, I got off track. So the ACE inhibitor inhibits the conversion of angiotensin 1 to angiotensin 2, which means ultimately we're going to stop that end result, which is the release of aldosterone. So we're not causing vasodilation, we are limiting a contributing factor to vasoconstriction. In addition, we are limiting fluid retention. I hope that makes sense. So Vasotec is used after nitroglycerin. Is not your first line drug for acute pulmonary edema, and this is still a fairly new drug in North Carolina, at least the pre-hospital setting. This was only added into the protocols a couple of years ago, but it works really well. So indications, obviously we're using it to treat pulmonary edema. It also sometimes is used to treat hypertension. We do not usually use it to treat hypertension in the pre-hospital setting. We would use a beta blocker or something along those lines if we were going to treat hypertension in the pre-hospital setting. All right, contraindications, hypotension. Why hypotension? Well, because it's going to limit arterial constriction, which is going to essentially cause arterial dilation, which is going to make the blood pressure get low. Hepatomegaly, that means an enlarged liver. History of angioedema. So here's something to think about. Patients have angioedema. Angioedema means swelling of the face, the mouth, the tongue, and it can be a life-threatening issue. And sometimes patients who take ACE inhibitors develop angioedema. And the reason why is because, remember, we're inhibiting or limiting the conversion of angiotensin 1 to angiotensin 2. So what happens over time is a patient who chronically takes an ACE inhibitor to treat blood pressure or to treat heart failure or whatever it is they're taking it for, then they end up with an increased level of angiotensin 1 in the body because it's not being converted to angiotensin 2. And in some instances, that angiotensin 1 can cause a type of autoimmune response, and the patient essentially has an allergic reaction to that buildup of excess angiotensin 1 in the body that was caused by the ACE inhibitor, not allowing it to be converted into angiotensin 2. So if a patient has a history of that, don't give them an ACE inhibitor. And end-stage renal disease, because this is greatly affecting the kidneys, and the video that I posted goes in detail on that. If you have questions, let me know. All right, so our dose is 1.25 milligrams, 1.25 milligrams IV or IO over 5 minutes. So 1.25 milligrams IV, IO over 5 minutes. You can go about this a lot of different ways. I like to hang it in a 100 cc bag of fluid and adjust my flow rate to make it run right at 5 minutes. I've seen people draw it up into a 10 cc syringe and just give a milliliter or two every minute or so. Whatever floats your boat, but just make sure that we are giving it over 5 minutes. Don't slam this drug because it will cause a drastic, unsafe drop in blood pressure and can cause some other issues. It is a pregnancy category D delta, so let's not give this to pregnant patients. Okay, we have other options. All right, continuing down, the last drug. There's only 3 drugs that we really use in the management of acute pulmonary edema, and that is Lasix. Lasix is the trade name. Furosemide is the generic name. So Lasix is a loop diuretic. And if you think of the word diuretic, what does it sound like? It sounds like diarrhea, right? So you've got a bunch of loose something that is exiting the body. In this case, it's going to be urine, right? So it flows. It increases urine production. It's exactly what it sounds like. It is a diuretic. But it does this via urine, not stool. Loop diuretic, that means it describes how this diuretic works. It's acting on what's called the loop of Henle, and we will talk more about that, but not right now. So long story short, Lasix gets rid of fluid. Okay, it gets rid of fluid. It makes you pee a whole lot. And people who take Lasix oftentimes pee so much that they take a potassium supplement. Remember that 98% of potassium is eliminated via urine. So if we're peeing that much, then we're also losing a lot of potassium. So patients who take Lasix take potassium. They kind of go hand in hand. But the reason that we would use it for the management of acute pulmonary edema is because, like your ACE inhibitor, it limits fluid retention. In this case, it's actually getting rid of the fluid. We used to use Lasix not as a first-line med, but a close to first-line med in the pre-hospital setting. We no longer do that. In fact, Lasix is very, very rarely given in the pre-hospital setting anymore. And in your state protocol, it says not to even consider giving Lasix unless your transport time is at least 30 minutes. So it's not a commonly used thing, but it is still given. It is still in your protocols, and so that is why we're going through it. Now, in the hospital, it absolutely is used, but this is a long-term management plan. This is not something that's going to fix the patient right this very minute. Okay? All right. Your dose typically is 40 to 80. The way your state protocol terms this is 40 milligrams or double the patient's normal daily dose. So 40 milligrams or double the patient's normal daily dose. Normally 40 to 80 milligrams a day is a very commonly prescribed dosage. So we may be giving 80, we may be giving 160, but 40 milligrams or double the patient's daily dose. All right, hope this makes sense.